I would say your doctor is in your pocket, like how you have a mobile phone in your pocket. If you told me that this could be done a few years back, I would have said, no way. Our rule is care for the patient does not end in the clinic. Diabetes is like a Venn diagram with two circles. She's gotten a second pregnancy. She's now in Singapore. So she immediately contacts us. So my nurse does a video call with her, explains how to check sugars and how to take the insulin. But I tell them diabetes is a marathon. It's not a 100-meter race. Now you could be a perfectly healthy person. You are on regular exercise, perfect diet, but still end up having diabetes.
You order food, you'll get it delivered within 10 minutes. You order your shirt, you probably will get it in another 1 hour. But how many cities or places or rural areas has it covered till now? There's still a long way to go for that. You'll be surprised to know that healthcare within India has gone to most of the remotest areas. No, doctors are not visiting there, but doctors are providing their inputs, their intelligence based on certain technology. And that we call it as today remote patient monitoring. Now, remote patient monitoring have been an essential part in India's healthcare journey, and it will continue to do so to make it a story that is there for the world to see. Today, we welcome one of the renowned endocrinologist and diabetologist and a remote patient monitoring expert, Dr. Subramanian Kannan. So, welcome to Healthcare Off the Clock.
Thank you very much. Thanks for this opportunity.
So, sir, remote patient monitoring is still a very evolving topic. I would like you to start with what exactly it is, how it works, and how has it evolved over the past 1 decade?
See, healthcare in India, as you rightly put, is very focused on the tier 1, maybe tier 2 cities. And even in those places which have good access to hospitals and good access to physicians, the care of a patient, particularly with chronic healthcare conditions, does not stop in the clinic. I go to a doctor, I go for my blood sugar or blood pressure, heart failure, heart issues, cholesterol. The journey will not stop in the clinic. The patients will have a lot of questions when they go back home. They may also have doubts, or they may have problems with the medicines given to them. They may want to talk to the doctor. It may be difficult for them to revisit the doctor for every small issue that they face. And as you rightly put, in the rural setup, the physicians out there might want expertise of the doctors who are in the metros. So remote monitoring is kind of I would say a pathway which kind of takes us or connects these people together, whether it can be the doctor with the patient or the doctor with another doctor, ultimately benefiting the patient in the long run. So our rule is the care for the patient does not end in the clinic. In fact, it starts with the remote patient care. And that's how the patient's care begins. We began remote patient care at Narayana Health hospitals even before COVID. I mean, from COVID, I think even patients started recognizing this system very well. But we began this even before COVID. And the archetypal disease for which you want remote monitoring is diabetes. I mean, because it's a chronic condition. It's not going to go away. It's going to be there with you, and you need to monitor it at periodic intervals. The intensity of monitoring could be very intense if you're on insulin 4 shots a day. Your monitoring could be less intense if you're on tablets. Regardless of how you are, you need to connect with somebody, an expert, so that you are on the right track. You don't deviate from your track too much. And so by the end of 6 months or a year, when you're coming for your annual checkup, things are fairly smooth and organized. And that's the whole idea of remote monitoring care. And I think with COVID, this expanded to a lot more disorders. I mean, blood pressure, heart disease, liver disease, kidney disease. So many things where a constant touch with the healthcare team is critical. I think that's where we are heading. And I think if a hospital or a clinic is not offering remote patient care, it's going to be very difficult for the patient to come back to the healthcare system for every single problem that they have. So I think I would say your doctor is in your pocket, like how you have a mobile phone in your pocket. But using the system very judiciously, they can actually get the expertise that the doctors and their nursing care and the healthcare team will provide.
Yeah. So, sir, now you've explained how it works, what exactly it is, and how it has evolved over the years. I would also like to know what's the channels that you are using, to spread this care across India or across to the rural areas.
So people who come to access our endocrinology or diabetes center automatically get the option of accessing this remote patient monitoring system. They are given information booklets. They are guided to the nurse who takes care through them in this journey. And we've now expanded this remote monitoring team just from initially we had a central hub, which was kind of expanding to many of the patients who visited the main hospital. But then now we have slowly taken and formed smaller units of these remote monitoring teams in various smaller clinics which cater to a local community.
Okay.
For example, if you see in the Bangalore city, there is a Jayanagar community which will deliver care to the community in that location. You have an Electronic City community which delivers care to the people around that location. You have some who are closer to the HSR complex community. So they contribute to the community out there. So while the main hospital receives a lot of patients who come from far off, and we still offer them remote monitoring and remote patient care, we also have smaller teams which do the remote monitoring for a smaller communities around that particular clinic. So I think it's two-way. You also help your local community. You also help people who come from far off places, other states, northeast part of India, who come to access care, and you offer that to them as well. And that's how we have evolved from providing this remote monitoring to patients, even patients outside our country. So patients who come from Bangladesh, Nepal. So we still continue to follow them through the remote monitoring system. So I think that's how we have evolved.
So in my introduction, I spoke about how remote patient monitoring has impacted India's healthcare, and especially rural healthcare and the healthcare across remote areas. So I just want to know a little more around this, like how a country big like India is getting benefited from this, and if you can speak about any personal story.
Patients who are from far off, thousands of kilometers away, and they have registered with our remote monitoring team. We still have some of our type 1 diabetes patients who are very obedient, very methodical, very regular with their follow-ups. They send their sugar readings to my nurse on the dot every 15 days once. Any major low sugar or a high sugar, immediate reports are sent and adjustments are done. Obviously, the remote monitoring is not the only solution for healthcare. Now let me be very clear about that also. That's not going to be the only solution, but for something which is chronic and requires constant patient healthcare team interaction, I think RPM, as we call it, the remote patient monitoring care, is really what connects the two groups together. I can give you draw another example for pregnancy diabetes. That's another we've had wonderful stories where the mother is located. So this is a patient whom we had personally taken care of in the clinic 5-6 years back. She's gotten a second pregnancy. She's now in Singapore. And she is so appreciative of the care we gave in the first pregnancy with the remote monitoring system. She immediately books an appointment and she does a video call with us and says, I'm pregnant now, I've got 6 weeks gestation, and I'm sure, and she's clear the diabetes is still running, she's going to handle the diabetes in the second pregnancy as well. So she knows that this needs a proper care, and she was quite happy, and the outcome of the first pregnancy was very good. So she immediately contacts us and we set up the remote monitoring system right away. We do a video call. She was new to insulin, for the first time. So she knew a little bit about how to take insulins and things. So my nurse does a video call with her, explains how to check sugars and how to take the insulin, and we restart the whole care again. She's far away in another country. And as the tradition goes in India, she moves back to her mother's home at the 6th month, 7th month. And I spoke to her today, and she's going to deliver in a month. So it's possible. And the baby is growing well. There are no signs of diabetes impacting the baby. She's now on 4 shots of insulin for the diabetes, and we've managed her sugars pretty well. Now, if you told me that this could be done a few years back, I would have said, no way. Patient has to come to my OPD and I had to see her physically and do this adjustments. But now I realize that, sometimes it's a mindset.
Yeah.
And moment you know that the patient is willing to do what you want them to do correctly, and you have a very good nursing team who understand the pros and cons of the system and can use the system effectively, this can be done. I mean, we've followed patients for 9 months without seeing them in the clinic.
Mm-hmm.
And the outcome of the pregnancy is fairly very good. We've not had any major problems.
Yeah.
So I think there are many more stories of remote monitoring care where things other than diabetes we have followed, including patients who have had low sodium, low calcium, and still, it really doesn't impact a lot when we have not seen the patient. And I think the remote monitoring is actually a boon to chronic medical health conditions that physicians manage.
So what we have experienced in India, smartphone penetration or smartphone adoption really happened when the internet penetration happened. So definitely that smartphone literacy has gone up. But there are still people, and most of the people in their later stages of life, post 40, post 45, they require a lot of care, right? And they are the ones who are not that, I would say, tech savvy, right? There's an issue with technology literacy there. How do you tackle all of that?
It is a challenge. I mean, I know talking to the patient over the phone or in the clinic, we get a fair idea of how well they will adopt this technology. Of course, there are sometimes they have people who will help them. Their grandchild can help them, or their son can help them sometimes. So that's family support is good. If it's good, fine. We don't have to worry too much about these things. But there are issues, and there are rural parts of India where you don't have internet connectivity.
Yeah.
So and the patient will pick up an old Nokia phone and tell, this is all I have.
Yeah.
And so you'll have to then, okay, all right. So we cannot say them to get a new phone. So what we do in those specific scenarios, and I will be very honest, those are a handful of patients. I mean, there are not a lot of patients. There are a handful of patients. Now, those patients are on our register. Mm-hmm. So these are patients in whom we tell the patient, you call my nurse between this time to this time on specific days of the week. And that's the time when the nursing staff are also not very busy with the other patients. So this is typically between, say, the 9 a.m. to 10 a.m. window where the day is starting and the new consults have not come into the nursing team yet. So the 9 to 10 is kind of a time when the patients will actually physically call them and tell them, okay, these are my sugar readings for the last, say, 7 days, 10 days or 15 days. These are the problems that I've had. Please check with the doctor and let me know what to do. Now, that's one way to tackle this. So patients are actually physically calling. Now, there are some patients who will not make the call also. So we have our nurses have a list of patients who are not technologically savvy to send their readings. And we know that these are patients who are at high risk for developing low or high sugars. So at that time, we tell them to make sure that you call the patient. So make a call once in 15 days or once in a month, just to ensure things have settled down, things are going on right. And if there are patients who require intense monitoring, then all the more reason we ask the nurse to call them up pretty frequently and ensure that they are on the right track.
Yeah. So RPM has been made possible to reach out to the underserved population and the remote areas.
I would say we have a long way to go.
We have a long way to go. Exactly. So I wanted to just talk about it. So how do you make that happen? I mean, smartphones are, I think, still a paucity in these areas, and still the penetration would take a little more time. So how do you really reach out to these people as of now?
I think our biggest asset in the remote monitoring team is the nursing staff.
Okay.
You need trained diabetes nurse educators. Now, these are nurse educators who have good knowledge about diabetes, who have good knowledge about diabetes medications, hypoglycemia management, troubleshooting high blood sugars, managing insulin, adjusting doses of insulin, under the supervision of the doctor, obviously. A doctor obviously cannot be made the driver of this process, because it becomes too much burdensome and the doctor will not be able to do it efficiently as well. So the people that we really need to make an army is the nurse educators. So I don't call them nursing staff, I call them diabetes nurse educators. So if we have to reach out to a lot more patients, we need to train a lot more diabetes nurse educators. And these nurse educators, with the help of these specialists in and around those areas or to a central hub, will really be able to scale up this model to a higher and higher level. And that's where we are heading towards. During COVID and even before COVID, I would say, there were a lot of patients who were from remote part of the northeast part of India, from Malda, from Cooch Behar, from remote parts of Assam, who wouldn't be technologically savvy to send their sugar data to us or send their blood reports to us periodically. What interestingly happened, and this was something that we never thought would happen, is they had small booths. We have seen the PCO booths of telephone, STD, ISD, PCO booths that we have seen. Now there was remote monitoring booths that were set up in these small towns, and they would upload all the document to the doctor's portal. We had our Atma, the software running. They would be able to upload it onto the software, onto the system, so that when we do the video consultations, everything is in order. You have all the documents in line, the medications in line, the labs in line. So the video call became much more a pleasant conversation, rather than half the time the conversation would be, what are your medicines? Here I don't have to waste my time with what medicines, what are the labs. Everything is sequentially put, and there are people who helping them out.
Okay.
I think this kind of a model where you have small internet areas, centers, which exactly know what the requirement of the clinic is. If they can support a lot of the far off patients, rural patients who don't have access to, who don't have that ability to, transact easily in the system, I think it'll reach a lot more places.
So I understand nurses play an extremely important role in in remote patient monitoring. But there must be other people like technicians, there must be other products that are helping you. So how do all of this come together to create and collaborate to establish a remote patient monitoring setup?
The remote patient monitoring is a teamwork.
Yeah.
And the components of the teamwork, obviously the center of this is going to be the nurse educator. And we should have, and we need to have good secretarial support to them as well.
Yeah.
So the secretarial support is to ensure that there are consults scheduled, there are video calls in whatever format you want. If the patient wants to have a phone call, there should be a phone call line. If the patient wants to have a WhatsApp call, a WhatsApp is connected. If they want to have a Zoom call, because WhatsApp is not part of their Middle East rule, then a Zoom call is set up. So whatever is convenient for that particular patient, a secretary should be able to arrange for that kind of a call. So you need a good secretarial support. You need a good nursing care. You obviously need the doctor who is willing to spend some time to take care of these patients remotely. You also need a good software. You need a good software which will integrate with your electronic medical record that you already have in your hospital. Now, remote monitoring care cannot be a standalone, product. It has to be integrated with your EMR, and that's where I think Atma Adi kind of merges or becomes one, where whatever you do on the Adi or on the Atma is integrated into the main system. So you don't have to worry about, when I see the patient physically next time or when I do a video call next time, I know what happened in the interim period.
Exactly.
And that gap is closed when you have a integrated EMR system. So I think that's very, very important. I think software plays a crucial role in ensuring that data sent from the patient is captured by the nurse. The nurse will then triage that data and present it to the doctor in a presentable format. The doctor will be able to give their instructions back to the nurse back to the patient. So this loop has to happen in a very heterogeneous way, because some patients will want certain aspects done. Some patients are WhatsApp friendly. Mm-hmm. They'll message on WhatsApp. They're convenient with that.
Yeah.
We respect that. So, when we had our earlier Microsoft Kaizala software, patients would use that software. So we respect whatever way they want to send the data, we will take the data in. So, ultimately that has to be integrated with your EMR.
Yeah.
So this is what I think RPM really should focus on, is there's a team that really works to ensure this loop gets completed day in and day out for all the patients that we have to serve.
So while we have spoken about patients who are coming to you, or we are reaching out to the communities, there must be patients who are getting admitted into the hospital, getting some treatment, and then their treatment must be going on remote patient monitoring as well. So what is the impact or what is it there for them in remote patient monitoring?
Yeah. Now, so what we've spoken so far is predominantly outpatient care, diabetes care, hypertension care, or But what we've also used remote monitoring is for patients who get discharged from the hospital. Now, this can be a wide spectrum of things. It can be for diabetes care itself. So patients who are admitted in the hospital for poorly controlled diabetes, they've had a leg ulcer, they've had treatment for that, they've had a surgery for their blockage in their leg arteries. When they go back home, we really want the sugars to be well under control. So you really have to monitor them closely, adjust their insulins regularly. So remote monitoring really helps those patients. Now, our counterparts in the Narayana Hridayalaya building, the cardiac center, they manage a lot of patients with heart failure. So these are patients in whom daily weights, pulse rate, blood pressure, oxygen saturation play a very critical role in seeing how they have responded to your therapy. If I give them a medicine to take the fluid out of the body, you want to see how much it is taking out and when do you want to back off. So remote monitoring really reduces readmission rates into the hospital. So about a third of patients, 30% of patients who would otherwise have had readmissions have now been safely transitioned back to their home care because of remote monitoring. Two other very personal examples that I would quote is patients who had pituitary surgeries. Now, this is a very complex surgery done by our neurosurgery colleagues. After this surgery, one of the critical elements that can go completely berserk is sodium levels. It seems like a very small thing. What will a sodium level do? But believe it or not, either a too low of a sodium or very high of a sodium can put the patient into a major neurological catastrophe. And so previously, before we had these kind of remote monitoring systems, we used to have patients come back to our clinic every third day or every fourth day with a sodium report. And it would, it'd be very difficult for the patient had to stay within the vicinity of the hospital to do so. And now we're no longer doing that. We send them back to their home, wherever they're coming from, ask them to remotely send their sodium levels at a periodic intervals so that we know when we should adjust their medications, how much of fluids they should take, how much of medicines that they have to take to limit their urine output. So many things can be done safely with remote monitoring. Similarly, patients who have had thyroid surgeries, previously we used to ask them to come back frequently for a calcium check. Now again, it's been taken care by the remote monitoring. So a lot of post-discharge patient care, which is very critical because you've done a major thing in the hospital. You just don't want the patient to just fall apart after they go back home. And you don't want to have them come back to the hospital for readmission. So readmission rates in general for our surgical patients, particularly which involves glucose, sodium, calcium, or for the heart failure element, are very effectively managed with this remote monitoring team.
And so I can relate very much to it. So almost 5 years back, a very close relative, so he was admitted for around 21 days into a hospital, and that is because of septic shock via sugar rise, via the diabetical interventions. So, and all of the dialysis and everything happened. So it was a very horrific experience. So I was there as well. Now, at that time, the family members were not aware about these nuances of diabetes and couldn't understand it at that point in time. And after like almost 4 days, they have already suffered for 21 days, and then just immediately 4 days post that, the patient started to have a lot of sweat, right? And in that moment, it kind of breaks down the family that what they will do again. They rush back to the hospital. And if in that era or in that hospital, I think remote patient monitoring would have existed, that panic situation would have been completely avoided. Or if they would have been given an option because they've already spent 21 days in the hospital, I think remote patient monitoring really eases the life of a family and really comforts them while sitting at their home. They can get the consultation done within few seconds.
Absolutely well said. I think when you have undergone a long stay in the hospital and when you're getting discharged, you really should know what are the things that you watch out for and what you need to do. And I think having a nurse care, regulate these things or triage these things really helps the doctor, it helps the patient, and the overall recovery process is also faster.
Yeah.
So I think this is a very important care element to post-discharge care as well. I think that's a very important tool of the remote monitoring.
So while talking to you and while talking about the discharge thing, so I understood one thing, when you keep someone on a very strict medication or very strict diet, they'll be kind of little, be opposite to what your thought process, right? And kind of be a little negative about it. And let's suppose you discharge them. There are a lot of distractions. There are distractions, where people offer alternate therapies. Like you will get corrected within 2 days, 3 days, 10 days, and you do this therapy, you will do that. And, lot of social media clutter, and I can vouch for it because everyone is a dietitian now. There are hundreds of people talking about the same topic in multiple ways. So one should really believe all that, or how to move away from that digital clutter? Because, we are at the end of the day human beings, and we kind of indulge ourselves in social media, and these kind of content is there. And most of it's not even verified. People are not qualified enough. But then that urge, of trying it, what's the harm? Already we are in such a position. So how do you see that as a consequence of the kind of care, maybe a stricter care that you have provided, but which is more beneficial and evidence-based for the patient?
Yeah, this is a very complicated area, and as you rightly said, there's a lot of cluttering with information, and you'll have to really tease out the right one from the wrong one. Now, one thing is very clear, and again we go back to the example of diabetes, because that's the classic example where people get misled sometimes with wrong information. Now, I've said this in my previous talks at the NH portal. Diabetes is like a Venn diagram with two circles. So you have two intersecting circles that contribute to diabetes. There is one circle that we all talk about: diet, weight, sleep, emotion, stress, anxiety, factors that are under your control.
Yeah.
But we forget the other ring. The other ring is actually the genetic ability of your pancreas to make insulin. Now, you could be a perfectly healthy person. You are on, regular exercise, perfect diet, sattvic diet, but still end up having diabetes. That's because the other ring was weak. You inherited bad genes from your family. And that will express itself as you age. So I think it's important to individualize your care. So take the right amount of information from your doctor, follow the therapy that is being advocated to the doctor. Again, it's okay to experiment a little bit. If somebody's, you want to follow a particular diet, experiment, but at the same time, be mindful what worked for someone else may not work for you.
Absolutely.
You should be very clear about that. So if you are going to experiment on a certain aspect of diet or lifestyle, then please ensure that you're monitoring your sugars more closely. And if that system works for you, well and good, but will it work for you in the long run? Again, you go back to monitoring your sugars and updating your doctor about it. So I am very open for patients to try certain things as long as it is not harmful. But I tell them diabetes is a marathon. It's not a 100-meter race.
Yeah.
You want to do some changes which is very dramatic for 1 month, I wouldn't really support you on that. But you want to do a few changes based on some someone that have told you, go ahead, do it. Monitor your sugars, update us through our remote monitoring system how you are doing. If it requires us to cut down our medications, we will.
Yeah.
And if not, and if you say you can't follow, it's okay. We'll still support you. We had a lady who's been following up with us for about close to 8 years. She was on insulin 4 shots a day.
Yeah.
And she, as you rightly said, watches the internet and says, okay, I can be free of insulin. And she goes on to this very dramatic diet. And lo and behold, she loses a lot of weight.
Yeah.
And her sugars do come down. But she's not able to sustain the diet even for more than 2 to 3 months.
Okay.
And when she goes back on her normal diet, her sugars just rebound back. And they come back with a bang. And we are back to square one.
Okay. So we've spoken about a lot of things, but we haven't touched upon the kind of elephant in the room, the AI part of it. So how do you see AI shaping up the remote patient monitoring in future?
Well, I think one of the things that I really feel artificial intelligence and data analytics should really help us is to create algorithms for patient care that can really help community physicians operate at the same level as what care would be delivered at a top level hospital, a top level. For example, let's take diabetes. If we can come back to diabetes example. So why should a patient travel all the way to Bangalore to get one of the top endocrinology care? They should be able to get that same level of care in their local hometown. They may not have an endocrinologist there. They may have a good primary care physician. They may have a good diabetologist there who can also provide them the same level of care. Now, they may also be young physicians who are willing to see a lot of patients in their hometown, in their rural area as well. What they might lack is the experience of someone who has seen thousands of patients and who's had the experience of making adjustments to a wide variety of medications. And that's where the gap between knowledge and gap between practicing healthcare comes in. I wish that artificial intelligence using the remote monitoring data and our electronic medical record data can churn out an individualized patient treatment algorithm. Let me give you an example. A patient comes to the doctor who's on diabetes medicine A plus B. Now the physician who's sitting with the patient should be able to decide whether I increase the dose of A plus B, or should I add drug C, or should I add A plus B plus C plus D, or should I add A plus B and then I add insulin. Now the algorithm that is given by the international organizations are quite complex, quite cost heavy. So a primary care physician will not be able to follow those algorithms very effectively. So what I really envision is an AI driven algorithm for nudging. I wouldn't say telling the doctor, I would say nudge the doctor to give him the answer to that question. Okay, this patient is so many years old, has so many years of diabetes. He's got 3 siblings who's got diabetes who are fairly well controlled on these drugs. His current HbA1c is this much. He's on drug A plus B. His serum creatinine is this much. His liver enzyme is this much. His sugars will come to under good control of HbA1c below 7% if I add drug C plus D.
Okay.
And if that AI can nudge, the primary care physician is now almost thinking at the level of an endocrinologist in a major city. So you see it makes a tremendous difference to how the diabetes care will get enhanced. Now again, it's ultimately the clinician's decision whether he wants to take up that recommendation from the AI. He can junk it and say, I don't want that, I'm going to do what I want thing to do. But I think over time, the AI will start becoming powerful and powerful, because it will start knowing who is that community that is seeing this patient, this doctor, what kind of medicines worked well for that particular patient. And so patient profiles, or we call them as, you can actually basket them according to their risk factor profiles. And you can actually deliver fairly accurate recommendations. And I hope that AI will be able to do that.
So with this, we conclude this episode as well. Thanks a lot for hearing us and hearing Sir. Hope you have had a very great time listening to all the insights that he has provided on remote patient monitoring and diabetes management. Thanks a lot. Thanks a lot, sir, for providing your valuable time. Sir, I would want you to look into the camera and request our audience to like, share, and subscribe to our Healthcare Off the Clock.
Thank you very much for this opportunity. I hope you've enjoyed this chat and you've gotten some useful information about remote patient monitoring care. I would like you to like, subscribe, and share the Healthcare Off the Clock